Thank you, Dr. Galea. So it's my pleasure to introduce our next speaker, Dr. Monica Bharel, who is the Commissioner of the Massachusetts Department of Public Health. She's a clinical assistant professor at BUSM and has been working on our campus for many years, and only recently did we lose her to the state.
Thank you. Hello, good morning. Good to be back home here with you. Nice to see you all. So thank you for having me. It's always a pleasure to follow the dean. A lot of what he spoke about, I think, will resonate as I talk about what we're doing at the state level. So I want to frame, I have a timer here, good. I want to frame my remarks today around the focus on data as strategy. So we're a room full of clinicians and scientists and evidence-based individuals here. And what I want to talk about is the way that we together collectively as a community of scientists can think about data and how the data and the understanding of what's happening with a complex, as you all brought up recently, socioeconomic, behavioral, medical problem can be addressed at the 35,000-foot view. So when you look at some of the poster abstracts and some of the talks that you'll have today, a lot is appropriately focused at the individual level. I'm going to take us up to the 35,000-foot level, and I'll walk through some of the ways we looked at the data here in Massachusetts and give you some specific examples about how we're using that for programming and policy. So as I start, a couple of things. So one is that when we think about substance use disorder and this current opioid epidemic and the multiple layers, as the dean spoke about, it's astonishing if you focus it back to one of the most important messages that I have had to continue to talk about outside of our scientific medical groups is how substance use disorder is a medical disease. And believe it or not, that has been incredibly challenging for individuals, a lot of individuals who are trying to do the right thing, but for a lot of individuals to grasp. And part of that is what the dean was talking about related to this concept of it being connected to behavioral issues, or the way it works on the brain, and the way people act in ways we don't expect human beings to act. And so outside of this room, we talk a lot about it as the medical condition that it is. And as we think about that and put that structure around it, we've said, well, compared to other medical issues, what do we know about it? And there's a lot of people in this room who have been thinking about addiction and the science of addiction and substance use disorder for decades. But there's not enough known about this medical disease to be able to then, at the 35,000 foot, come up with a platform and a policy and a programming platform that actually we can confidently say will make inroads as it relates to the current rate of deaths. So let me walk through for you some of the work that we've been doing since 2015. Try that button. There we go. So if any of you have worked with the data at the Department of Public Health, and there are individuals in the room who we work directly with, you all know that most data that we release for a variety of reasons has about a 2-year lag to it. And when we were looking at the data related to this current opioid epidemic, we said, well, if we look with a 2-year lag, this epidemic is changing and fueled by things that are changing every month. And that won't be able to give us the information that we need. So we said we need to be able to put out data that is more up to date. So starting in 2015, we started to put out quarterly reports that for the first time ever went from a 2-year lag in opioid death reports to a 3-month lag. And that in and of itself, understanding who is dying, why they're dying, how they're dying, and putting the pieces together was one of the really important parts that helped us to understand this epidemic. So to show you, I hope some of you have seen this, but this is our opioid-related overdose deaths. I'm going to go through a bunch of data, and at the end I'll give you a link if you want to look at it more in depth. So if you look at this, this tells you a couple of things. So first, this 2-year lag issue. So this is our last report, goes through December it goes through 2017. And the next one, which goes through March of this year, is coming out shortly. And if you look at the red areas, that is predicted deaths. Because of the way deaths are recorded and the Office of the Chief Medical Examiner evaluates them, that's part of the reason why we have this 2-year lag. So at the Department of Public Health, for the first time, we developed and predictive model that can say, and that was validated to say, we can predict which one of those deaths will actually be from opiates. And that really allowed us to push this data forward more quickly. So that's what that red is. A couple of other things to note on this. You know, it's quite obvious that if you look from 2000 to now, you see this marked increase in the number of deaths. Here at BU and at BMC, we've been dealing with addictions and substance use disorder and previous opiate epidemics. That's why I always refer to this as this opiate epidemic for many years. One of the reasons that this current opiate epidemic has captured a broader audience is because of the sheer numbers of death. So if you look at the last few years from 2013 on, you see that sharp increase. And that kind of increased rate of deaths from any one disease we haven't seen since the early days of HIV. So it really became this call to action of how do we act because it's so startling that there's this sheer number of deaths. So that was an important piece of this. And you'll see that, and maybe you've heard this in the news, that in the last year, we're one of just a handful of states that has actually finally started to see a decrease with this 8% decline. And I'll talk a little bit more about that as we go. So as we were looking at these death rates, and I'm going to talk a lot about numbers and these 2,000 individuals. By the way, that's like 4 jumbo jets full of human beings, you know, crashing and dying each year. And I'm going to talk really high at the really high level about this, but I'll say it now and then I'll go back to the numbers. I'm a primary care internal medicine physician and deeply care about the individuals and the individual stories and the narratives behind these. So let's look, when we saw these numbers of deaths, we said, let's look at these deaths. Who are these individuals? What can we understand from the information we have so that we can really deeply understand what's causing this current opiate epidemic? So this is looking at, so I'm going to show you some of that right now. This is looking at toxicology of individuals who died. And what you'll see here is the dark blue line is fentanyl. So this, I hope, is not new news to you, but one of the primary reasons for this current rate of death that we're seeing is the introduction of illicit fentanyl into the markets across Massachusetts and other places. And somebody asked about the national picture and why does it look different, and the role of how fentanyl has been brought into different states and different regions is thought to play a role in that. So if you look at the fentanyl line, you'll see that in some point at the end of 2015, it crossed over with heroin. And if you talk to individuals who use illicit drugs and buy them, they'll say it's very difficult to find heroin even if you want it. Many individuals are scared to use fentanyl, but when you're buying it, it's hard to find something that doesn't have at least some fentanyl in it. This is individuals at the time of death. The dean also mentioned that there's multiple different pieces to this epidemic. If you look at the prescription opioids level, you'll see that that's the bottom blue line. And that's relatively consistent, about the 20%. Remember that at the time of death in these individuals, it's not prescription opioids that are playing the key role. However, when we look back at individuals who die, 4 out of 5 of them do, in fact, start with a prescription opioid. So they're kind of intertwined in a way, but at the time of death, this is what we're seeing. This is looking at the opioid overdose death rates by county in Massachusetts. We've done a lot of work with hot-spotting maps. If you look here, you'll see the darker the color, the higher the rate of opioid overdose deaths. And there's a couple of things to point out here in this particular one. If you look from 2011 to 2016, you'll see unfortunately, the state continues to get darker and darker as the rates of opioid deaths increase, just like we saw on the other graph that I showed you. But I also want to point out that many times with addiction, we have focused on our urban centers, and that's where we see the highest numbers of death. I think you asked this question earlier. One of the things that we're seeing with this is that it really spreads across our state. And as we look to how we have done programming and policies in the past, many are very urban focused. And so as we broadened our scope of thinking about how we get interventions to all of the individuals who need them, we had to really think from the rural hat in the Berkshires to the suburban and continue to work on the urban. So it's been one of the factors that we've had to work with is how do we make sure across the state in the multiple different ways communities can accept these services and talk about these issues that we're able to provide them. So if we hadn't done the rate, for example, we wouldn't have seen the issue in the Berkshires in the way that we did. We're cutting and breaking down the data in lots of different ways. You heard again the dean, thank you for setting me up so nicely, talking about the life expectancy decrease that we've had in the country that is really fueled by the young white male interaction with this current opioid epidemic. But as we broke down the numbers in Massachusetts by race and ethnicity, this is some of our findings where you see, yes, the rate of increase of death, this is looking 2014 to 2016, the sheer numbers are highest among white males, and there's been an alarming 50% increase, but there's an almost 50% increase in our Black non-Hispanic colleagues as well. And if you look at our Hispanic colleagues, it's a 100% increase in those 2 years. So as we develop at the state level our response, we want to make sure that we're engaging with all communities in Massachusetts and making sure that everybody who is exposed to this epidemic gets the resources they need. This is a prescription monitoring program. Usually when I come here, somebody in clinical practice pulls me aside and talks to me about what they think about the PMP. I'm happy to talk to you on the side if you'd like. I will tell you that for years, Massachusetts was one of the first states, as we proudly are in many areas, to have a prescription monitoring program that was homegrown, if you will. It was kind of built into the existing system. I used it when I was at Boston Healthcare for the Homeless and when I was here at BMC all the time. It was hard to use. It was tedious. It took 11 different clicks to get in, multiple minutes, but it helped me in my clinical judgment of trying to prescribe a medication and understand somebody's pain versus judging potential for opioid misuse. So as we were working towards the governor's initiative of making the PMP required for use before opioids, we really wanted to revamp the system. So we went with a vendor, which many individuals are now, there's new companies that have vendors, and through a competitive process, the vendor that we currently have, the system is much better, easier to use, and we're in our final stages of working on fully integrating it within electronic health records to make it easier to use. What you see here is that the green bar is the prescription monitoring program, and that wide jump, so talking about policies, that wide jump is when it became required by law to use the prescription monitoring program. You will see also the blue bar, which is the Schedule II opioids in our communities in Massachusetts. And that's gone down about 29% since 2015. So again, at the 35,000-foot level, and many people also talk to me about their individual patients who couldn't get the pain medicines they need. But at the 35,000-foot level, the sheer number of opioids that we have in our communities across Massachusetts has gone down. So that's some of the information from our quarterly reports, and there's lots of other things in there, but in the interest of time, I'm going to stop there, and I hope I've piqued your interest to continue to look at those, because every time we run those reports, we learn more important information about who's dying from this. But as clinical public health individuals, we care about getting upstream from the deaths, if you will, and understanding what risks individuals have, who's at highest risk for opioid misuse, how does the prescription connect to the eventual overdose death, what do we do when individuals have non-fatal overdoses, et cetera. And this led us to our Chapter 55 work. And I think this crowd in particular, many of you in the room as I look around have helped us on this work. This crowd in particular will be interested to know that at the Department of Public Health, we have a lot of data. Maybe some of you report into the department. But the way the laws are structured, pieces of information, so pieces of data, cannot be brought together and used to develop patterns and understand individuals in ways which is crazy, because our individual patients don't just go to the Department of Mental Health, or they don't just use Mass Health Services, or use a Bureau of Substance Addiction Services, right? So when we're trying to understand the full picture, we have to be able to bring this together. And believe it or not, it took a law change to be able to decrease those barriers and bring the data together. And because we had the political will around the current opioid epidemic, we were able to have the law change so that for the first time ever in Massachusetts, we're able to bring together multiple data sets at the state level in a precision public health way so that we can start to better understand how to help the individuals who need it on the ground. So we're in our third year of this process. In our first year, we had a legislatively mandated report to answer 7 specific questions. In our second year, we enhanced that and also increased the data sets that we put in, and I'm going to review some of that data with you now. We're now in our third year, and we have a notice of opportunity out for individuals to help us with that work. So just to show you a little bit of what the database is, this is just to give you the visual of the different buckets or silos, if you will, of data. So I was really amazed to see that the gray buckets are within the Department of Public Health. And I think the third day I got there, I said, oh, we need to understand how the information in the prescription monitoring program interacts with our Bureau of Substance Addiction Services. I just need to put that together because I think there's a vast amount of knowledge we can gain from this. And it wasn't possible legally. So that's why, just to give you a flavor of how we had to do the legal change in order to bring this together. But now it's an unbelievable amount of information that we have where all of these data sets are linked, and we do it in a way where the information comes together and answers questions and then is disaggregated. So from a security point of view, we could feel much more confident. So this has been really monumentous for us to further understand what we need to do in this epidemic. And this piece, the next piece I'm going to tell you is very important. These are the partners who came together. You'll see BU, you'll see BMC represented here, and our colleagues here in the audience were involved. There were no new funds to bring this data together and analyze it. It's important you understand that. Any funding that goes to substance use disorder at the state level goes towards the services. So to be able to bring all of this together, we really had to work, again, as a first, on public-private partnerships, where there were individuals in the community, including the community here, who said, how can we help with this current opioid epidemic? How can we offer our resources on modeling, on big data analysis? And in turn, it was an opportunity for many people to look at this big data in ways that they hadn't been able to before. And it's through these partnerships that we were able to do this work. So we really couldn't have done it at the state level without all of these experts who are involved, many of them here today. So let me just give you a couple of things that we were able to find. So this is the first phase. So clinical individuals, I know there's a group of enlightened clinicians here, but clinical individuals across the state say to me all the time, what can we do for this current opioid epidemic? And they're amazed when I show them this sheer fact. So we know there's decades, some of the researchers in this room, of evidence that methadone works as treatment for substance use, for opioid use disorder. Buprenorphine works. But what this did is we looked in Massachusetts. So I should say this data was 2011 to 2015. And what we found is that following a non-fatal overdose, if patients are treated with methadone and or buprenorphine, they were less likely to die. So if they were engaged, that's the blue bar. If they were engaged in opiate agonist treatment versus not engaged, it's about a 50% reduction in death from opiates. You know, people know this. There's lots of data on this, but something happened when we took this and we made it Massachusetts specific. Clinicians, policymakers, people who run programs looked at it differently. And what's even more startling is that when you look at this information, we saw that when someone presents with a non-fatal overdose, only about 5% of them, 5%, actually get put subsequently on methadone or buprenorphine. So from the clinical realm, the sheer clinical realm, translating big data into what can we do clinically, this is the call to action clinically. What can we do to decrease? Everybody wants to decrease the opioid deaths. How do we do that? We treat people with the medicines that work to treat it. So this is really important, and this was a real learning for me because someone who's read and reviewed this literature for a long time, I didn't think we needed to prove this point again. But something happens when you localize data and you make it something that people can relate to tangibly. This has been incredibly powerful at the political level, at the policy-making level, the programming, and the individual clinician level. And I won't have time today to talk about all the different ways in which we're trying at the state level to help change this paradigm, but know that this piece of information, data, has been critical. Data as strategy. I'm like out of time, but I'm just going to go for a few more minutes. Thank you. This is another thing that we found, and I put this up so that you could see the way that the questions were asked, these 7 questions that we had to ask, they were asked in very legalese statute ways. So those are what you see on the left. And we had to change those into analytic questions so they could be things that we could then analyze. And then we had a result that we, you know, when you look at the preliminary findings, from being able to digest information and put it out to non-clinical, non-scientist form, we had to have a bottom line. And so this is just an example of two of the bottom lines. One, that there's a 7-fold increase in risk of fatal opiate overdose when individuals go to multiple doctors. And part of this is how we, in a data-driven way, could say, therefore, it helps us as doctors to check the prescription monitoring program before we prescribe an opioid. Similarly, when you look at benzodiazepines, a 4-fold increase in deaths related to benzodiazepines. So hence, when you look at the law that says first-time prescribing benzodiazepines, check the PMP to see what the opiate history is. It's connecting the policy and the legal changes to what we're finding by analyzing this big data for the first time. Data strategy. In year 2, we really had these 3 buckets that we were looking at and trying to answer questions within. And in the interest of time, I'm just giving you a few samples of what we looked at. Number 1, this is looking at the prevalence of opioid use disorder. So prevalence, so I was like, okay, fine, it's 4.4% in Massachusetts, age over 11. I don't know, I'd done this work for a long time. I thought it was kind of high. 4% of individuals in Massachusetts had opioid use disorder. It's about double what people predicted before. And, you know, diabetes is about 8%. But when we show this, sometimes people say, so, you know, like, what should I do with this? This is the basics of the disease. We have very little information about how this disease is impacting us in Massachusetts, and this was really building. If you're trying to decide at a state level how many resources you need and where to put them, how can you do that if you don't even understand the prevalence of the disease you're looking at? So this is really building those building blocks for programming and policy purposes. This is looking at non-fatal overdoses. Most people in this room know that non-fatal overdose is one of the greatest predictors of fatal overdose. I showed you that, linking it to whether people get started on medications or not. And this is just looking at the number of increases in non-fatal overdoses. And as we, I hope, continue to see the death rate go down, we probably will continue to see more non-fatal overdoses, more naloxone use, and more what we began to see in 2015 and continue to see is this increased need for naloxone. So as we're doing our training and understanding how individuals who are lay people should know about using naloxone, this was an important part of it. Fentanyl's entering the picture. You need multiple doses of naloxone. How do you educate people around that? This is looking from time of initial treatment to the overdose death. And what we found here, you know, survival curve, what we found here was startling, that for the individuals who did die, so not everybody who gets a prescription dies, but going backwards, for individuals who died, from their time of death, if you go back to their first prescription, it's about 36 months. So really, this slide has helped from the political policy lens to say, we don't have 2, 3, 4, 10 years to develop the laws we need and put the changes in place. We need to work now, fast, and do things quickly in these current cycles in order to make changes. And then of personal interest to me around health equity is to understand who is at increased risk so that we're targeting our limited resources to those at greatest risk for opiate overdoses and deaths. So the next few slides shows just a flavor of some of the groups we found who are at increased risk for us to target at the state level our resources. Number 1, I hope many of you know about this. This is about individuals with a history of incarceration, 120 times higher risk of opiate overdose death, 120 times. This fact alone, and there's lots of subsequent pieces of information breaking up houses of correction, Department of Correction, et cetera, but this fact alone has opened up our capacity to speak with our criminal justice colleagues in ways that we've never been able to before. So when you talk to individuals in the correction system who are also trying to do the right thing, many of them who don't have the medical scientific knowledge like the individuals in this room said, I didn't know this. I thought if they're locked up and I dry them out, when I release them, right? I mean, it was the basic understanding that, you know, I've done my part of it. So having information like this has really changed our capacity to talk with our colleagues in criminal justice and say, what can we do differently, or what do we have to do differently? Again, maybe it's something everyone in the room will say, well, we knew that already, but not everybody knew that already, and it wasn't in a way that was digestible that they could then take in and make policy changes around. You may have seen that several of the houses of correction across Massachusetts applied to and have from our Department of Public Health grants to start to think about how they can do medication before release and do warm handoffs into community, and we're slowly making change in this area. Some of you know I was at Healthcare for the Homeless for 12 years and saw this firsthand, but we really hadn't been able to capture how housing instability, except for clinical anecdotes, how housing instability and homelessness affects opioid overdose risks. And we saw in our work for modeling homelessness that there was a 30 times increased risk if somebody was homeless. So again, how do we target interventions? And when we think about recovery, recovery being supported by housing and housing as health as part of this component. And then individuals with serious mental illness, we're doing a lot of work with our colleagues at the Department of Mental Health. Many of us in the room know, but it's not a well understood fact, that often individuals using opioids are self-treating, self-medicating under or untreated, undiagnosed mental illness. So putting the two together and understanding even something as simple as depression has a threefold increased risk of opioid overdoses. And then pregnant and postpartum women. This has really opened up the way that we're working with individuals who care for women who are pregnant with OUD, as well as the hospital systems who care for their newborns with neonatal abstinence and substance exposed, as well as programs that continue to support moms after delivery. If you look here, this is the first year before delivery. That's their rate of opioid overdose events. It goes down. Maybe that seems reasonable as they go through pregnancy. And then the highest risk for overdose is actually in the 6 months to 1 year phase. So as we looked at that, it's really opened up because most people don't get the same intensity of services in that time. So again, from a program policy point of view, it's really enhanced the way we do our care. I refer you to this site. I don't have time to go through it with you now, but if you get a chance, check it out. It goes by every town and city in Massachusetts. You could toggle over the town or city. Community groups are using this. I mentioned in the beginning that the response to the opioid epidemic is very local based on the community we're dealing with. And this gives in facts for each one of them. Again, a first time we've put a response like this together. I've spoken in this kind of form before about the Governor's Opioid Working Group and our action plan. There were 65 recommendations we made, a lot of them based on data-driven approaches, including a 19-step action plan. You can find this online. I'll highlight some that were related to safe prescribing, which I mentioned as I was speaking. We did a lot of work, including Dean Ontman-led BU Medical School here, to develop core competencies that are now taught in every medical school, and in fact then the dental schools quickly followed, as well as the others on the list. This is the social work programs in Massachusetts taking this up. This is voluntary, started by the 4 medical schools in Massachusetts, core competencies that every student will learn. Part of why we did this is because the Student Coalition on Addiction came to talk to me and said, we don't feel prepared when we graduate. They were leaders in this, the students. If there's any students in the room, you should feel proud of this. We came together. Dean Ontman was a real leader in this, as were our other colleagues here. Put together core competencies. If you're interested, we published on it in Academic Medicine. You could see all of the competencies there. And now 8,500 individuals who graduate from these programs in Massachusetts get this mandatory training, nowhere else. I recently met again with the students, and the students who are graduating right now have told me that they see visible differences. They can see the difference. There's a couple of campaigns we're running, including State Without Stigma, around the stigma of opioid use, which is a real issue in terms of people not getting even the assessments that they need. This is our parents campaign. Parents told us they don't know how to talk to kids. They have no idea how to bring up opioids. We don't want to talk about pills. We don't know how to talk about this. This is a campaign that helps parents. I talked about our Latino colleagues. We released it in Spanish as well and have advertised it widely in the Spanish news media as well. I don't have time to talk about naloxone, but some of the primary work was done here and throughout the state now in having access to naloxone as that first Band-Aid, if you will, and we're one of the states leading in this still on naloxone access. We've increased the number of beds. Usually somebody pulls me aside also and says we don't have enough beds in Massachusetts, but this is the greatest increase that we've seen in a short amount of time. We do need more beds, but we also need more access to treatment like we would with any other disease in multiple different ways, and we're working on that. And then recovery is key. We're keenly focused on recovery and how to help individuals find a place other than, I know from my own personal clinical experience, going back to the shelter system, and how can we have other options. I went way over time, and I apologize for that. I want to make sure you all have the helpline number. I used to use it and not find it that helpful, to be honest. But we've revamped it, and we've tried to make it more real time so that when you call and you say you're a clinician, you can get some information in a different way and know what beds are open. It still needs work, but it's a work in progress. All of the data I spoke about is under that second link. If you're working with communities, parents who need resources, this Stop Addiction, many parent groups have used and find it very useful. Thank you for your time and for having me here today.
First of all, you didn't go over time. You did perfect. So there's nothing to worry about.
This thing kept blinking at me. So
yeah, I don't know why that is. Don't worry about that. So we have some questions.
Thanks, Monica.
Hi,
my question's more about upstream and prevention, since you mentioned the upstream phenomena. When people mention, like you did, that when you ask folks what was the first opioid they used, they say prescription opioid.
Mm-hmm.
But at the national level, when you ask people what's the first substance you used and how old you were when you used it, it's tobacco,
Yep.
alcohol, and cannabis.
Yep.
So my question is it, I'm assuming it's the same in Massachusetts, that people who are misusing a prescription opioid, that's not the first drug that they're using. And if that's true, what really can we do? The prevention programs are complicated to get them in the schools, and what are your thoughts about sort of primary prevention based on that?
Yeah, thanks for bringing that up. It's a really important point, and I didn't have enough time to speak about all of the primary prevention work we're doing, but as you alluded to, when we look at our behavioral health surveys and the youth surveys, it's those three agents that people use first. So they're using alcohol, they're using tobacco, and they're using marijuana at a youth level, so the entry point, right? And we know that if we can get children to the age of 18, 90% of us who are going to be addicted, it happens before the age of 18. So that is a really core, important age. Yesterday was our annual Kick Butts Day, where we talked about tobacco and nicotine, and one of the most startling facts that I was given is that in surveys, so this is self-report, in Massachusetts, 43%, so almost half of high school students say they've used e-cigarettes. So this is really, really important, and we have to pay attention to it, right? So beyond the priming your brain for potential opiate use, beyond the direct effects of the nicotine, we as adults in the room are a little bit behind on this, and at the Department of Public Health, we're doing a campaign that should be out at the end of May or early June around, it's our getoutrage.org, which our site exists, but it's really more information, this time, again, focused around parents, because I don't know what you find, but when I talk to parents, and I talk to them regularly about e-cigarettes, many people believe that the vapor is not harmful. Many people with kids in high school believe that there's not nicotine in it, that it's flavored, you know, because they come in these horrible flavors like mango, bubblicious, and all that, right? So, so we need to do some work in there, and as marijuana becomes legal, our focus at the Department of Public Health, as it is legal, and you know the industry grows, our focus is around youth and how we message and talk to youth about it. So I think it's an excellent point. You know, talking to young people who have used, or people in their 20s, they do say, though, that there was something about, and this is in some ways very parallel to me with the e-cigarettes. I don't know if you've seen these jewels and bows, but they're really sleek. And apparently they're called like the iPhones of tobacco or something. So they're really sleek, they look really attractive, you can change the stickers you put on them. It's clever marketing, right? We've seen this before. In the same way, people talk about how pills, because this generation of young folks have grown up taking pills for things, they watch their parents take pills for things, it felt different to them than, say, injecting heroin or even, you know, snorting cocaine. So I think the two are really intertwined, but it's an excellent point you bring up. In the governor's current opioid bill, there is a trust that would be created to put funding towards schools having money to do more primary interventions. We work very closely with the school nurses and with the schools. We've done, you may know that in the last opioid bill, Esperit became required at the school level. So most of the school districts in Massachusetts have been trained through the Department of Public Health. So everybody decides if it's going to be at the guidance counselor level or the school nurse, or depending on their resources, who will be doing those screenings. But that's also coming into play in the next school year. So just a couple of examples. So it's a really important issue.
One last question. You had one question. How about you?
Oh.
To the left.
Thank you. My question is, you talked a lot about quantitative data, and I'm curious about how qualitative data has informed policy.
It's a great question. The question is around qualitative data. And we've done some work in that area. I do think there's more that can be done. You know, when I talk about these individual clinical narratives, and you know, that's in a way the qualitative piece of talking to individuals and understanding their stories. We had an EpiAid project with the CDC, so where the CDC came in and helped us along the South Shore, and I can get you the link if you'd like to see it in the MMWR, where we talked to individuals. So individuals who are using were interviewed with select questions on what it is they're using and how. And from that, one of the ways we found, at least on the South Shore, is that most young people were using and therefore then overdosing in their homes. So it really opened up a way to think about interventions in a different way than we had before. So we have some qualitative data, but I agree we need much more in that area.
Thank you very much.
Thank you.